All right, so I think we are just so thrilled and honored to be able to have our next speaker with us. This is Dr. Kimberly Workowski. She's a professor of medicine in the Division of Infectious Diseases at Emory University and serves as medical consultant to CDC, coordinating the development of the CDC Sexually Transmitted Infections Treatment Guidelines, which is the national and international standard for the management of STIs. Welcome, Dr. Workowski.
Thank you for allowing me to talk about my favorite infection, and an infection that I continue to be humbled about. We can be doing our business for a very long time, and in my instance, a very long time, multiple decades, and I continue to be perplexed and humbled by this infection. So what I'm going to try to do this morning is talk a little bit about the emerging epidemic that we're having, as you all know, in terms of syphilis, congenital syphilis. I'm going to talk a little bit more about congenital syphilis because it has relevance to our women with syphilis. Delineate some interesting new findings in terms of syphilis treatment and management strategies, and then we'll talk a little bit about Doxy PEP as an STI prevention strategy. So we'll start with this patient of mine who had secondary syphilis, and this is when he presented 13 months ago. He had an RPR of 1 to 128. He got a single shot of benzathine. You can see on the exam, he actually, his only manifestation of syphilis was in his mouth. The lesion on his lip was not syphilis, but it was herpes. So again, STDs travel together, and you need to think that when you see one thing, that another thing is probably there as well. So his only manifestation was in his mouth, and he was totally asymptomatic, didn't have any findings at all in his mouth. He declined HIV PrEP. He returned to the clinic 11 months later after treatment, again declining PrEP, and had an RPR of 1 to 64. So tell me which reason for an inadequate serologic response after treatment for early syphilis is not correct. So this again is an HIV negative individual who declined HIV PrEP multiple times. So I'm going to stop you now. So I'm glad everybody's confused, because that's what everybody gets confused with syphilis and syphilis serology. So we'll get to this at the end, but the bottom line is that the correct answer is actually C, and that when you have an inadequate serologic response to syphilis, the things that can interfere with the serologic response are A, B, and D. And Doxy PEP is very difficult. When this gentleman was actually sharing Doxy PEP, so we don't know how much he was taking. He was sharing it with friends, as friends share things, and especially Doxy PEP. And so he was taking it. So you can't really know what the heck is going on with your serology when somebody's on Doxy PEP. That's something that's really challenging. So take an infection that's even more challenging to diagnose and add Doxy PEP on top of it, and you have a patient that develops syphilis in the middle of Doxy PEP, and you're scratching your head on what to do. So let's talk a little bit about the epidemiology. So you may have not known, but the recent CDC surveillance report just came out, and for the first time in 15 years, there's been a decrease in syphilis. Thank goodness. Primary and secondary syphilis decreased by 13%, both in MSM that were HIV negative as well as HIV positive. However, there was still an increase in syphilis in women. And remember, there's two epidemics going on in the United States. One that's occurring in gay and bisexual men, the other that's occurring amongst women. And again, congenital syphilis is unprecedented. We haven't had rates this high since 1992. This is a little bit interesting graph that just came out from the surveillance report that I want to have you look at. You'll see on the left in MSM and then men who are having sex with women and women. And what continues, you can see the folks that are HIV negative have had a continuous increase in syphilis. So again, raising the point that it's really important that these folks get talked about with HIV PrEP. And as the patient that I talked to you about before, he declined for various reasons, did not think he was at risk. So this continues to be the group of people that we really need to be serious about with getting them on HIV PrEP. And then syphilis and behavior. I showed you the difference in what's happening between men and women in terms of the surveillance, but this is behavior, and they don't have the behavior data yet for 2023, but for 22, it's just very interesting. So on your top left, you see sex and behavior in women. Women, the current epidemic is really associated with using drugs and drugs while intoxicated, whereas in men, it's anonymous partners. So this is really something to think about. Those of you that have been around before know that we had this epidemic of crack cocaine in the late 80s, and that's when the rates went sky high. Now it's meth and opiates, and transactional sex is back. So syphilis can do anything. The graph that I have for you on the left is a nice article, a review article from a couple of years ago that looks at the different stages of syphilis. And syphilis doesn't follow the rule books. You don't have to go from primary to secondary to tertiary. You can make all kinds of tours along the way. And one of the things to really point out that early CNS invasion happens. Just like, remember, syphilis is a spirochete, just like Lyme disease, Borrelia, and it disseminates when you have early infection. So up to 40% of it 40% of people with early syphilis has CSF invasion and have it in their CSF. Most folks don't have any symptoms because their immune system is able to clear the infection. But again, you can go from primary to latent to secondary, so it can be very confusing, and they all travel together. What I have there is reminding you about cardiovascular syphilis. This is a patient that we saw in clinic, got treated appropriately for secondary syphilis, 20 years later showed up with a new murmur, and you can see the tremendous aneurysm that he had. And on path on the aneurysm, we didn't find the organism, but he had histopath that was compatible with syphilis. And then we're seeing increasing brain presentations as well, which we'll talk about in a little bit. So this is my favorite slide, and I know Dr. Maurer is going to love this slide. But these are all my patients that I've seen in my clinic. And again, the manifestations of syphilis are just mind-boggling, and I continue to be mind-boggled by the presentation and things I think that aren't syphilis that turned out to be syphilis. So I basically say, anything, if you don't know what's going on, get an RPR, because it's just quite amazing. I want to point out two, and the bottom, and where's my pointer? I don't think I have a pointer, but the bottom one, the bottom right corner, that looks like maybe tinea versicolor, or this gentleman was seen by a colleague and had an RPR 12 times that was negative. But a diagnosis was made on a skin biopsy. And again, somebody that's got advanced HIV can't mount an immune response, and you're not going to get even a treponema response in those folks. So you'd have to do a biopsy. So we talked a little bit about treponemes getting into CSF. It's common in early syphilis. Thinking about who should ULP. This is what comes up all the time. When should somebody get an LP? Somebody's got neurologic signs and symptoms. They've got things such as cranial nerve findings, stroke, altered mental status, uveitis. You need to ask all these questions about the eyes and the ears. Somebody with tertiary disease that presents with the aortitis I showed you, or gummatous lesions, which can be more common now in HIV. The diagnosis of neurosyphilis is tough because we don't have a definitive test. You need combination of tests to make the diagnosis. CSF, VDRL, if that LP is full of blood, you can get a false positive test. You have CSF pleocytosis and protein, and the CSF VDRL is only 30 to 40% sensitive. So what's a person to do? If you have you have to kind of rely, I say, on my spidey sense, or you call a friend and say, help me with this, because I don't know what to do. And then think about why you're LPing in the first place. What are you going to get from it? A patient that comes in with, that you think has otic syphilis, you don't need to LP them because their LP is almost always negative. If they've got isolated uveitis and isolated ophthalmologic disease, you don't need to LP them. The management is the same. So again, this is complicated, and most people get a little bit nervous because of all the complications that can occur. I'm not going to go over this in general. There's a very nice article on neurosyphilis, a review in clinical infectious disease by Matthew Hamill. He did a wonderful job of looking at what we determine is asymptomatic versus symptomatic neurosyphilis. I'd recommend that you look at it. I don't have time to go into it, but we can go into it in the breakout session, go a little bit more in depth. But it's a wonderful summary of the complicated track of neurosyphilis. So I'm going to quickly show you some graphs on congenital syphilis. I'm not sure how many of you guys treat kids, but this is not about kids, it's about the moms in particular. And when female rates go up, guess what? Congenital syphilis rates go up. And as I mentioned, over 3,000 cases. It has affected every county and every state in the United States. It is just horrible, and it's really at epidemic proportions. What I have on your left is a vital signs that came out several months ago now, looking at why we're having an increase in congenital syphilis. The biggest concern to me is what's in the middle box. So everything in blue is our missed opportunities, that you have a diagnosis, you have a positive RPR, but you didn't get the mother treated. That's horrible. This is a public health emergency, and there needs to be quick communication. I was just dealing with, last week, a poor 18-year-old from rural Georgia who was allergic to penicillin and couldn't get desensitized because the lower half of our state in Georgia doesn't allow for desensitization. They don't have the staff to do desensitization, and especially the patient was uninsured. That's a tragedy, and that's what's happening. People don't have the expertise of know what to do, in particular with pen allergy. So that you are aware, HHS is aware of this. There is a task force that's been stood up, and you'll see down below the states that have the priority jurisdictions, which are the rates of syphilis and the highest in the country. And so what do we need to do? We need to be innovative. We need to get vans out there. We need to do mobile testing. I'm going to talk a little bit about point of care tests, and we really need to think out of the box to get this test for the people that are actually needing it, the uninsured, the people that do not speak English, who are afraid to come into medical care. So we need to really, from our public health systems, really be innovative. Show you some characteristics of a recent paper that looked about women that had congenital syphilis. Again, STIs travel together. Low education, differences in race, lack of insurance, and again, initiation of prenatal care late. I wanted to mention two things about screening. The STI treatment guidelines, and I've had the opportunity to work with CDC for almost 30 years now, helping them develop the STI treatment guidelines. And over the years, the recommendations have been to, of course, get a test initially when patients present for care, but then there's new introduction of risk-based screening or prevalence based on what's happening in your community. Recently, I wanted to make you aware of ACOG basically said with this epidemic we're having, everybody should get triple screening in pregnancy. And so they have a new clinical practice bulletin, but remember, each state has different requirements on what's required for prenatal care. whether or not they will pay for it and what their rules are. So it's a very murky kind of battle, so I really applaud ACOG for having recommended universal screening in pregnancy. We had the opportunity to write an article, a review article last year on congenital syphilis. And again, I'm just mentioning this because it is such a tragedy, and I'm not going to go into depth, just to say that it's there for you to go for. That's got all the state-of-the-art recommendations and just these heartbreaking pictures of little newborns with congenital syphilis. Then who do we screen? This is a big problem. Who do we screen? Most of you know that we have screening recommendations for men who have sex with men, transgender women, HIV, HIV PrEP, pregnancy, but many of you may not know there's now prevalence-based recommendations based on the prevalence in your community. This is a map that looks at the prevalence of syphilis, and there are now recommendations that have been for the past year to screen every adult sexually active in counties with a high prevalence of syphilis as a way to try to identify syphilis in populations and communities that have high prevalence of syphilis. I want to next move from epi to laboratory testing, which is very challenging. Mentioned you a couple of documents. The WHO came out with a document recently on laboratory testing. The CDC just released laboratory guidelines for the diagnosis of syphilis because it's so confusing. It's confusing to my colleagues, it's confusing to all of you, and it's because these tests are, to be honest, crappy, and they were developed decades ago, and they miss a lot, but they're the best we have at present. There's a table here for direct detection. We don't have a point of care direct detection. Most people don't have dark field. Most people don't know how to interpret dark field. And so what's a clinician to do? There is no commercially available nucleic acid amplification test, although several companies are looking at them. What I list for you in a graph is a study that we did, a sub-study of a treatment study we did on syphilis, showing that even in people without lesions, in primary and secondary, we can find the organism in the mouth 30 to 50% of the time, even in early latent. So think about that, what that means for transmission. Very intriguing. So point of care test. The National Task Force just came out with a really good primer on who should be getting a point of care test. Remember, these are treponemal-based tests. They're not going to be helpful in my STI frequent flyers that have had syphilis 15 times. But in people that have not had syphilis, these are treponemal-based tests. I don't have time to go over all this, but what it tells you is the difference between the point of care test, who to use them, who not to use them in, that they wouldn't be useful. I find it extremely helpful. The big picture is they're not as sensitive as lab tests, and think of them as when we had OraQuick for HIV. It's kind of similar. We want to refer them to laboratory-based testing. But if it's the only thing you have to a population that's not being accessed, you can do a quick treponemal-based test, and if you can't get the person into care and they're pregnant, they get a shot of benzathine, right at the point of service. So that's how I think that these tests should be used. And again, take a look at this. It's a wonderful document. So what we're left with is crappy tests. You can either start with a non-treponemal test or a treponemal test, and people ask, well, which is better? I say it just depends. It just depends on which is better. If your person has had a lot of syphilis, you don't need to be starting with a reverse sequence algorithm. But again, this is complicated. We'll go into depth about this during the syphilis section this afternoon. But remember, in primary syphilis with an RPR, you're going to miss the infection with your lab test 30 to 40% of the time. The treponemal tests they're much better in terms of picking up primary syphilis, but not helpful in people that have had previous syphilis. And then these are your estimates. It's really good at secondary, right? It's the primary that you have problems, and then as you go into latency, you start to lose some of the reactivity in your RPR. So let's end with treatment. I list for you, at the top, there was a great conference earlier this year that, on alternative treatments for syphilis. And what's mentioned there is the older treatments we used to use for syphilis and how long benzathene's been around since 1952. I list down there on the bottom left what the current treatments are. Primary, secondary, early, late, and whether you have HIV or not, it's a single shot. And we finally proved that in a trial. We're waiting for the final publication, but this was presented, the data was presented at ID Week. There's equal equivalence of 1 versus 3. So remember, folks, we have a shortage of penicillin. You don't need to be treating people with 3 shots for early syphilis, just because it makes the provider feel better. There's actually data now that shows that you don't need to do that. The other kind of little secret here is for latent syphilis, we really don't have good data that we need 3 shots. It's recommended that we give 3 shots, but we don't have data. It's based on historical data. And again, we can go into more in depth about that as well. And then what I list down below, very frequent co-infection. So this was a kind of another sub-study we did as part of this treatment study that showed up to 1/3 of patients with syphilis have gonorrhea and chlamydia at multiple sites. So don't forget about that, as you need to screen for everything. Also recent data about the Jarisch-Herxheimer reaction. Again, that 1 versus 3 study, we did a kind of a sub-study on Jarisch-Herxheimer. This has really never been done. And this was presented ID Week, and the publication is under review, showing us a little bit about the data. The median onset of the Jarisch-Herxheimer is about 5 hours, duration is about 12. And if you do have the response, you're more likely to get a serologic response. And you'll see down below that there's a difference in terms of the symptoms, whether you're positive or negative, and that HIV infected individuals are less likely to have a JRH reaction. There was a horrible shortage, there still is, of benzathine. Colleagues in France have given us some doses of exicillin, and there is a CDC document if you can't get benzathine. This has kind of calmed down a little bit. I think that production has increased, and you can let me know if you're still having problems with benzathine, but it's our drug of choice. The other thing is when we were having this shortage, people were jumping on the doxy bandwagon for syphilis. And it does work for early syphilis. It's just that I can't assure that my patient's going to take it reliably. And truthfully, I don't have a duration of therapy, I can tell you, that that syphilis needs to be taken for it to be completely eradicated. Can you trust yourself taking something twice a day for 14 days? Now, do you expect your patients to take something for 14 days? So I don't know what the answer is. I know it works if people take it regularly, but I just don't know if they're going to do that. What about pen allergy? We're going to go into a little bit more in depth in terms of this session this afternoon, but less than 5% of people are really, truly pen allergic. There was a nice article that talked about oral graded challenge, and I'll go into this more in terms of my discussion. It's another thing to do, and using an algorithm that you can truly decide if somebody is truly pen allergic. Lastly, I just want to end about our pipeline. So it's only recently that we're able to cultivate Treponema pallidum in the lab. Most of you know about the Treponema pallidum rabbit story and know that we injected treponeme into poor little rabbit backs and testicles to kind of cultivate that. Now we have an in vitro culture model where we're actually able to grow up the organisms, look at different antimicrobials, and then figure out what their MICs are. So this is just a long list of different antimicrobials that have been looked at where we have in vitro susceptibility results. This is the condensed version. So for early syphilis, some of you may be horrified that dalbavancin is on there. I didn't pick the drugs. It just has activity. I'm not recommending it. What we haven't read are what's the alternative regimens. We have ceftriaxone. where we have limited data from 20 to 30 years ago. We don't know what the correct dose is, but you have to give it IV or IM for 10 to 14 days, and we have doxycycline. Again, I don't know what the minimal duration of therapy it is. You need to kill it. There is an ongoing trial of doxy versus benzathine in France, and linezolid actually works. However, there was a trial that was done, published in The Lancet. Why they use 600 milligrams a day versus BID, I don't understand, but that's the dose they use, and it didn't work. There are new studies going on looking at a twice-a-day therapy. For neurosyphilis, we have ceftriaxone, and we did have Procaine, but that has been unavailable in the United States. Since we started having a problem with benzathine, the company that makes the product switched to making total benzathine, is not making Procaine anymore in the United States. And just an aside, in the UK, the preferred therapy is actually Procaine penicillin daily versus IV penicillin. So we need a new therapy, and there's currently a clinical trial that is being planned using an oral drug versus IV penicillin. What about other cephalosporins? So we do have some early trials that we're looking at cefixime, 400 milligrams twice a day for 10 days, that looked, small numbers, but it looked good. But again, you're talking about a drug that has to be taken a day for 10 days. And then what about pregnancy? So there's a trial that's being looked at in women, because those trials were done in men. This is a trial being done in Brazil looking at cefixime, and if everything looks well, the plan is to look at this product in pregnant women. So for neurosyphilis, this is something that we used at our workshop, looking at the minimum criteria that we need and the ideal characteristics of the drug. And so looking at kind of what's left. And what's left really going forward is doxycycline. And the trial that is being planned is a trial based on a small number of patients that was done in the UK that used doxycycline 200 milligrams BID for 28 days. Now that's going to be hard to tolerate, but that's kind of what was used. And there is a trial that is going to be looking at that dose going forward with IV penicillin. On syphilis management, these 3 papers, don't have time to go into them, but they're really important. One is syphilis. It can alter the way syphilis looks. So it can be less severe in terms of the second, third, fourth time, or really strange looking. And remember, if you diagnose somebody with syphilis, but you have to wait a week or 10 days to get your patient back, you need to repeat your RPR, because you're going to look for your titer drop, and the titer drop can change within that period of time. And then the last paper, which is interesting, which we'll get into later this afternoon, is, okay, so who do I LP, and what happens if their titer doesn't drop at 12 to 24 months? What do I need to do? And this paper, which was a paper in China, showed that even in folks that got LP'd at 12 months, these were HIV negative individuals. It didn't matter whether they got LP'd or not. The occurrence of asymptomatic neurosyphilis was extremely low. So our challenges, I'm going to end in 2 minutes, talk about DoxyPEP. So the challenges that we have going forward for syphilis is all these STIs run together. We've got HIV, we've got STI, viral hepatitis, and substance use disorder. I mentioned that these things are atypical the way they present. We've got test shortages, diagnostic test shortages, we've got antimicrobial shortages, and we've got limited point-of-care diagnostics. We now have an at-home syphilis test, but it's a treponemal test. And what's your patient going to do with that that's had syphilis a bunch of times? Pretty much nothing. They still have to come in. The point-of-care test I have down there listed for you. They're treponemal tests. They're inexpensive. They should be used in populations that have poor access to care. So let's talk a little bit, the remaining minute, about DoxyPEP. So there's been a number of studies showing its efficacy. And I'm talking about DoxyPEP, not DoxyPrep. There are some programs that have advocated DoxyPrep
taking daily doxy, which is not what I'm talking about. I'm talking about doxy after sex. For chlamydia, syphilis, and gonorrhea, there have been decreases. However, thinking about Doxy PEP, which patients to use them in, we still need to think about antibiotic stewardship. Personally, I am not into writing a prescription for 90 pills for my patient and giving them 3 refills. That's not antimicrobial stewardship. Patients, you have to see how much they're using and have them ask for refills. My own personal practice is they get 14 pills with 0 refills, and then they need to contact me if they need refills. And they have to come in reliably every 3 months and get their STI testing. So think about, this is a shared decision-making between you and your client. They still have to be STI screened. Though what you have on the right is the STI doxycycline post-exposure prophylaxis guidelines from the CDC. But there are consequences. There's no free lunch. There's always consequences. So I would advise you to read the 2 papers listed below about the way that bacteria share DNA. And there may be consequences between other bacteria, our intestinal bacteria and our skin flora. This is a recent paper that showed you can't induce resistance to doxy in vitro, which is really important because that's always something we're thinking about. Will this organism become resistant to doxy? However, other organisms, it's a concern. In particular, it's a concern in gonorrhea. And these are data presented at the STD Prevention Conference showing an increase in doxycycline-resistant gonorrhea over the past couple of years. And then the last 2 slides are basically increases in tetracycline resistance in Staph aureus and group A strep. And think about this in terms of skin flora and whether or not going forward this may affect community-acquired pneumonia guidelines and skin and soft tissue guidelines. So again, thinking about this is a great intervention to use, but it's also we have to not push it out to the community. You have to be thoughtful in terms of who you're giving it to. And again, no sharing. So I want to end with my case that I presented to you early. So inadequate serologic response. This is in people that have inadequate serologic response, people that have syphilis many times, people that have treated for syphilis over a year ago, and people taking Doxy PEP. This patient showed up after he got treated for the syphilis, where he was sharing Doxy PEP intermittently with his friends. 5 months later, he presented with painful ulcers, bilateral femoral adenopathy. All his testing was negative except that he was HIV positive and his RPR was 1 to 2. Probably because he was taking, again, this intermittently. So how am I going to treat this patient for syphilis? I gave him benzathine and he was cured. And then we got him on ART. So in summary, syphilis is complicated. That's all I'm going to say. We have new tools. We have to be innovative. And we've got some targeted interventions to your affected population. So thank you so much for your attention.
Thank you. While we're waiting for folks to either come up to the microphone or pass in their cards, I might just, we actually got a question earlier during Dr. Mauer's talk, but I think hopefully you can answer it. How, in your experience, how long, so for people who are having dermatologic manifestations of syphilis, how long after appropriate treatment would you expect the sort of clearance of the skin findings?
It just depends. In people that have advanced HIV, it can take weeks. And I think they get scared. So they'll send pictures, and it can take weeks for things to get better. The other thing is if they're co-infected with something else, we have to remember about that, and they can also be co-infected with bacteria. And especially things that have been long-standing. They said, oh, I got something caught in a zipper, and I didn't think anything of it, and it's been 3 weeks, and now this is how it looks. And now it's super infected with staph. So it's a complicated question, but if you're very immunocompromised, it can take a long time. And I usually say weeks. And then in between that time, they can get reinfected again. So that's why it's so complicated. And then how do you interpret what you have in front of you? And then you have to take a good sexual history, and if you don't know and if they've been re-exposed, then have they been re-exposed and reacquired syphilis again? So, you know, I always tell my folks, you know, and you have documentation of your partner getting treated, please show me the RPR. Show me the treatment, and then I'll have sex with you.
Thank you. All right, go ahead, please.
You mentioned about the lousiness of diagnosing CNS syphilis with an LP. Do you ever empirically treat someone that you really think has neurosyphilis and not doing an LP? Because I've run into patients that, oh, I had friends that had an LP and had complications, and even if I reassured them that I've actually never seen in my 17 years of practice that have a complication of a lumbar puncture, but...
Yes.
Then yes, there are people that
We would empirically treat if they refuse the LP.
do you do it often?
No.
Even, okay.
No, and I think the other thing that, in fact, one of my cases that I was going to show this afternoon was an individual that was an IV, so she had extensive lesions, was an IV drug user, and I'm not staying, you're not making me stay, and had severe headaches. And again, we don't know if the headaches was because she was feeling bad or not, and she refused an LP. And so it's the negotiation back and forth with how you're going to get her treated. And sometimes we'll talk about that later this afternoon, or I can talk to you later about it, but I think the point is sometimes it's negotiation, right?
All right, so several questions about when you consider someone being serofast.
So complicated question, again, because the serology is complicated. The recommendations for primary and secondary and early latent, which you may not be aware of from the 2021 treatment guidelines. We'll talk about somebody that's HIV negative first. In primary, secondary, early latent, we use 6 to 12 months. So 12 months, looking for that fourfold decrease. In latency, it's 24 months. However, in HIV, it's 24 months for whatever stage of syphilis you have. And so, again, I think the problem with folks that are very sexually active is they're having sex, you're trying to interpret the serology, and you don't know what to do, right? So you have to, again, be a good clinician and ask about, is there anything going on? Severe headaches, eye findings. Tinnitus is the other thing that's really important to ask about. So, and you have to look everywhere. I can't tell you how many people don't examine certain parts of the body. And so whatever I ask is, what's being penetrated? What source? I mean, where is it? And let me look at the site. So again, you have to look at every potential site every time they come in. You can't diagnose syphilis by a blood test. It's a combination of a crappy test that we have and a physical exam and a history. It's not easy, sorry.
Appreciating the real talk. Okay, let's see. I think some folks found your mention of Doxy PrEP very intriguing. Sort of if you could just talk briefly about that. And then can you just talk about best practices as far as sort of refills? Is that okay to do as a telephone encounter, in person? You know, how does that roll out in practice?
I can just say this is my personal opinion, whether you're a provider or a public health, if you're running a public health program, I think there's two different approaches. I'm going to as a provider. And as an infectious disease doctor who's also an antimicrobial steward. So I do have people in my practice that are extremely high risk and continue to get STIs despite what I educate them in our discussions together. So I do have people that I want to continue to engage with. Talking to folks in the community, what is being done to me is horrifying in terms of having parties where the admission is $5 for a doxycycline tab, or instead of having M&Ms on the table, have Doxy PEP. And so again, the individual decision of having to do this and engaging your people, just like with PrEP. People come on and off PrEP, they're going to go on and off Doxy PEP. And so I want to have that dialogue with them and talk to them about that. That's the way I'm approaching this system, and thinking about that what we do one place has implications somewhere else. The data that I showed you, I wanted to show you the data on the group A strep and the Staph aureus, because I use Doxy a lot for Staph aureus infections. I hate clindamycin personally. It's not well tolerated, and I use that a lot. And so I'm thinking again on other common things that people have, and again, just to be engaged. So that the reason I'm a little triggered by this was somebody asked me about setting up something in Epic for doing a order set in Epic. And order sets in Epic to me means you don't think. And I'm sorry. It may be easier for providers, but I think we need to use our brain with this important intervention. And you need to continue to engage and just don't keep pushing the refills. Yes, I do telehealth and do things by telehealth. People show me things, or I say, show me a picture, send me pictures through Epic or whatever. But I think it's an important intervention that if we want it to last, we have to be thoughtful. This was done with minocycline in the 1970s, and it didn't last. So again, think about what you're doing, and it's smart to use in the appropriate people.
Thank you. All right, how would you encourage providers who are really trying to develop relationships, work things out with their local OBs to raise awareness, or then also potentially ERs if the provider doesn't have like in-office capacity to do an LP in someone that they think might be indicated? Any encouragement for navigating that?
So we go down to the ERs as ID docs pretty frequently and get the pulse of what's going on with the ER docs, and then establish a relationship with your OBs. Most OBs don't stock benzathine, so you're gonna know when they have a case of syphilis. They're gonna come down, and the case I'm gonna show this afternoon was pretty horrifying, and similar to what Dr. Maurer had. It was a 65-year-old lady that came in wanting an exam, and she hadn't had a gynecologic exam in years. And they looked at what she had, and they said, this is cancer. And they biopsied it. And the questions weren't asked about sexual behavior, substance use, that kind of thing. And it looked like a cancer to them. And so the point is, make some allies. And have somebody that they can trust, that you guys can have a trusting relationship. I get texted or emailed once a day about syphilis from everybody, asking questions because it is hard. And can I run a case by you? You have to be there for people. There's also a national warm line, an STD warm line, that you can call to talk to an STI expert about things if you're just not sure about what to do and want to run a case by somebody. This is team science, right? You have to share, and you have to talk to people when things are complicated. And if you can't figure it out, phone a friend.
Thank you. All right, I think we have time for, one question at least, unless otherwise, or folks are trying to make their way to the mic. If you could just briefly touch on, I'm not sure, you may have touched on this before, but if the clinical history and exam is very, very suggestive, and someone has an exposure, what are your thoughts on sort of empirically treating for syphilis prior to having any lab results back?
Can I say hell yeah? Yes, you need to treat on site. And the other thing is that you can do, depending on your institution, if you have a reflex, depending on whether you're using remember, a treponemal test is more sensitive for primary syphilis. And so if you can order both, everybody does it different. Sometimes the RPRs go to treponemal test, sometimes you do the treponemal test first, but the treponemal test is more sensitive. So yes, if you're suspicious, please treat, yes.
All right, wonderful. Thank you
You're
so
welcome.
much, Dr. Workowski.